There we go.
Good morning, everyone. Hope you're all having a great conference and dealing with our technical difficulties every once in a while. I'm Aurora Aguilar, editor of Modern Healthcare, and it is my distinct pleasure to introduce Mickey Tripathi, the new National Coordinator for Health Information Technology at the ONC. He's here to share his perspective on what we can expect over the next 4 years under the Biden administration regarding data sharing and interoperability regulations, as well as the role of FHIR, patient-facing apps, and the future of interoperability. Please join me in welcoming Mickey Tripathi.
Great. Thanks so much, Aurora. I'm just delighted to be here. I always like to begin by just sort of reminding all of us what the journey that we've been on and where we are right now, because it has been though it's been somewhat of a short journey in relative times. A lot has happened over the last 10 years. So over the last decade, we've spent something like $40 billion in public dollars alone to build a foundation of EHR systems. We started in 2010 with the passage of the HITECH Act and at that time, there was something like 10% of provider organizations were on electronic health record systems. And after a lot of money, a lot of public investment, as well as private investment, both in real dollars as well as in sort of the blood, sweat, and tears of the individuals who spent a lot of time implementing systems and getting adoption on them. We're now at the point where we have something like 85 to 90% adoption of EHRs across ambulatory providers and hospitals, and that's a relatively short time when you think about the complexity of the healthcare delivery sector of the U.S. And healthcare is something like 15% of the U.S. GDP, and I would argue that every sector of any sector in the economy, healthcare is by far the most complicated. Not only because of the just the complexity of healthcare in general, but also because of the fragmentation of the industry on the supply side and the demand side, which makes it particularly challenging to do things like have widespread uniform adoption of IT systems and health IT systems, and be able to have those act in more and more unison with respect to interoperability and capabilities that we want to be able to establish across the industry. So that's been a sort of a huge achievement. And I think on top of that, the adoption of FHIR-based capabilities. And for those who aren't familiar with FHIR, FHIR is an emerging standard for healthcare interoperability. In internet terms and in technology development terms, it's actually a very familiar approach to interoperability because it's based on RESTful APIs, which are the way that the rest of the internet works. For those who are using Amazon or Twitter or any other browser-based technology that you use in your day-to-day life, that's based on RESTful APIs, and that's exactly what the convention that FHIR has embraced as well. So the adoption of FHIR is a really important sort of milestone for the industry to move us forward into richer patterns of exchange. And already what we've seen is that something like 80% of providers across the country are on EHR systems that have FHIR-based capabilities in them. So you take those two things together: one, the foundation of electronic health record systems, as well as the rapid embrace by the industry of FHIR. Then that just sort of spells a lot of growth and a lot of change in a relatively short period of time, but a lot of opportunity ahead. And so, where we are now, I think it's just sort of an important pivot point for us as an industry, because we've sort of got the systems in place that do the baseline work of clinical documentation and payment, right? And I think all of us would agree that those are the baseline sort of capabilities that those systems have to be able to do. They have to be able to support basic medical records and medical record documentation, and they also have to support payment. People have to get paid for doing the work that they do, and those are very, very important core capabilities. But I think hopefully all of us would also agree that that is not the hope and promise of what electronic health records and interoperability can offer. And that's, I think, where we are now. We're sort of at this point where we're able to stand up and say, there's an amazing amount of hard work that was done in building that foundation, and now how do we think about what it is we want to do going forward? And so that's what I'd like to talk about now, as we think about what ONC is working on and what all of us can do together as we move forward, with this hard work behind us. One of the first things, though, I certainly want to not overlook is COVID and the immediate needs of COVID. So we do not, for a single minute of a single day, take our eye off the ball with respect to COVID response and getting us past this pandemic. And I think, as all of you know, and you've been following the news, things are looking brighter and brighter in the U.S. at least. Obviously, there's huge inequities and huge disparities across the world. In the U.S., things are looking brighter and brighter, but that doesn't mean that that we take our eye off the ball. It certainly doesn't mean that from an HHS or ONC perspective. So one of the things I think that we've learned, from the pandemic, is that for everything that I just talked about, having laid the foundation of electronic health record systems, I think one of the glaring things that we saw in the COVID response and the challenges that we had in the COVID response, particularly in the peak of the COVID crisis, was that we weren't able to successfully and effectively leverage those electronic health record systems that we had put into place, which is unfortunate, and is certainly one of the things that that I think all of us, as we look really hard at what lessons have we learned, that's sort of a key lesson, I think from my perspective and from an ONC perspective, as we think about that, which is we laid the foundation. We wanted those to be able to be things that would be, sort of used in the time of need, and perhaps it was just too early in the trajectory. But we now want to make sure that what it is that we're doing, sort of is something that's fully embraced for us as a nation, so that when we, so we're able to use those systems both to prevent the next pandemic, but also to the extent that that we do, have the misfortune of being in another pandemic, that we have a much better response that leverages all of the tools at our disposal, to be able to respond to that. So the specific work that we're doing with respect to COVID is we are co-leading an executive order work group that's related to the executive order on ensuring a data-driven response to high consequence public health threats. ONC and the CDC are both co-leading that work, which is very important work that looks at assessing what we learned from the from the COVID experience, identifying key gaps, and then working on the modernization program to say, how do we create that public health ecosystem of the future that that doesn't have some of the gaps that we witnessed as a part of this crisis. And I think that that at a high level conceptual sort of way, the way that we've been thinking about that is to say that the public health data systems had lots of issues, and some of them were about asking those systems to do things that they weren't designed for. Some of the things were about the systems just falling down when they were pressed, and some of them were about the siloing of those systems from the clinical systems. So we have a whole EHR sort of foundation that's laid to support clinical care. We've got sort of payment infrastructure that supports payment, isolated from the pipes that are that have been built over many years to support public health needs. And I think as we move forward, a part of what we're doing with that work group is is asking the question, how do we make all of that a part of a single ecosystem? So that we say that we have a clinical care ecosystem. Public health is just one part of that ecosystem. That's much more dynamic, that leverages all of the foundational capabilities that are available, and that does it in a bi-directional way, because it isn't a very interactive system right now as well, which is one of the key things that we saw, meaning that there's a lot of one-way static reporting out of systems, not a whole lot of information coming back to those on the front line to help inform them, how they can best respond in their localities and in their settings that they're working in. So that's a lot of the COVID focus that we have right now, and a lot of hard work there. For those who are interested, excuse me, the Health IT Advisory Committee, which is the federal advisory committee to the National Coordinator's Office, we had a full day hearing last week on the 13th. On public health and public health data systems, and there was just a great set of panelists and experts from across the country, from the federal level, from industry, from local level, who provided a wide variety of perspectives on that and open discussion about the challenges that we saw and perspectives on how we might move forward. That information is available. That full recording, audio, video, as well as transcript, as well as all the presentations, are available on the ONC website. If you go to the high tech part of our website, you'll see all of that information available. So hopefully that's helpful to everyone. So that's what we've been really focused on and doing a lot on COVID. And as I said, we're not taking our eye off the ball on that one, but we also have a whole bunch of other work as we look at the work that was already, sort of in flight and the work that we want to be able to accomplish over the next few years. So, some of that derives, from the 21st Century Cures Act. So, as many of you may know, the 21st Century Cures Act was passed and signed by President Obama in December of 2016, and that had a couple of components that are incredibly important for health information technology and for interoperability. One is the information blocking piece of that rule. And the information blocking, piece is an incredibly important part of, how we think about interoperability going forward. It's, basically was a statement, a very firm statement by the Congress and by the administration at that time that we needed to flip the way we think about information sharing. That it's not about just sharing information based on HIPAA permission, but having that be something that's that's just considered as optional, or when I get around to it, HIPAA permits it but doesn't require it, to a perspective that says that if you're a provider organization, if you're a technology developer, if you're a health information network, you actually have an obligation to share the information that's permitted by HIPAA. So it's about being proactive rather than just reactive and under duress, as it were, in many cases. So that's a real culture shift and a real change in sort of approach and paradigm, which I think is very important. So as we think about sort of the processes and the and the requirements that underlay that, an important piece of that is the EHR certification rule, which puts into place a requirement for FHIR-based APIs in EHR systems and certified EHR systems by the end of 2022. That got delayed a couple of times over the last couple of years, but we are very much focused on making sure that doesn't get delayed any further, and that we do everything we can to try to accelerate the industry adoption actually of those capabilities, even though the rule has that milestone at the end of 2022. So the applicability of information blocking went into effect on April 5th. Again, it had been delayed a few times over the last few years, but we did work hard to educate and inform the industry that the date was April 5th, and that did go into effect. And now we're doing a lot of work to try to educate the industry and respond to all of the understandable questions that arise from something as complicated as that. So we have a lot of educational outreach. We have traveling roadshows, virtual traveling roadshows of our clinical team and our policy team, and we welcome anyone who'd like us to engage specifically with your organization to help to answer questions, to understand your concerns, and to be able to engage in more direct ways with the details of the information blocking rule. One of the things I think that hopefully all of us appreciate is that something that complicated has sort of the big P of policy and the small P's of policies, which is to say that you've got a law and then you've got the rule. Can't possibly address every single circumstance that people experience on the ground in, as I described before, the most fragmented and decentralized part of our economy, which is healthcare delivery. And so we recognize that it's an ongoing process to be able to identify what are the areas that are gray areas, what are circumstances that perhaps weren't addressed specifically by the rule, and how do we understand what those are, and then provide additional guidance to the industry and additional information to the industry on how to translate that from what the rule says. So rather than feeling like that feedback from the industry is pestering, we actually welcome it. I mean, I think that's a really important part of the process. So so we encourage everyone to contact us with any concerns, questions you have, and I promise that we are actually looking at every single one of those and trying to do the best that we can to incorporate what is the concern there, and figure out what is the best vehicle, whether it's an FAQ or a webinar or sort of other kinds of approaches to be able to get the information to be responsive as possible back out to the industry. I know an important consideration for information blocking as well as the enforcement aspect of it, and I just want to touch on that for a second because obviously it is a regulation. Compliance is a part of it. There are no kidding civil and monetary penalties associated with it. So enforcement is obviously something that people have a concern about. So the rule is got the collaboration among a few different agencies. So ONC is responsible for the rule itself and for the policy related to the definition of what is information blocking, and that was what went live. Was a final rule that was passed, that was made available over a year ago, but that went into effect on April 5th, as I described. The enforcement of that is sort of a shared responsibility, though, which is to say that for things that that are related to to certification, those are things that are within ONC because those are for technology developers who have certified systems that go through the ONC certification program. But anything else, and that could be the vast majority of things, those would go to the Office of the Inspector General, who are separately, but obviously in a collaborative way, are responsible for the enforcement of the rule and the policy that's created by the ONC rule. There is a draft rule out, I think, as many of you may know, that's there available in the public. We expect that toward the end of the year, there'll be a final rule from OIG on enforcement. So, we can all look forward to that as with respect to the details of the enforcement, even though, again, just reminding everyone that the applicability of the rule did start on April 5th. Another important thing to understand about the about the enforcement aspect of it is that, as many of you may know, the rule covers providers, which is a broad definition of providers. So that's something to look for if you're a provider organization to make sure that you have an understanding of whether you're covered or not, because it's not just hospitals and ambulatory providers. It covers long-term care providers, LTPAC, everyone in the LTPAC community, physical therapists, a lot of categories of provider that is much more expansive as defined by the 21st Century Cures Act. So that was intentionally expansive in the law, and so that's covered by the rule. So that's one important thing to understand. So it covers providers, technology developers, and health information networks, health information exchanges. The civil monetary penalties cover the technology developers as well as the health information networks. But on the providers, the law specifies appropriate disincentives to be defined by the Secretary of Health and Human Services. So that is work that is underway, working with with HHS at large on defining what those appropriate disincentives should be. And I think it's just important to note, and we'll certainly have more information forthcoming when we have a timeline for when that will be available. But one thing that I want to make sure that everyone understands is that those appropriate disincentives are the law intentionally said the Secretary of Health and Human Services. So that's not just a CMS thing using CMS levers, through Medicare and Medicaid, for example. That is HHS wide. So that could cover research grants. That could cover grants from other agencies within the Department of Health and Human Services, all as a part of appropriate disincentives for any providers who are found to be not in compliance with information blocking. So it is sort of broad in that sense, and I just want to make sure that that everyone in the industry understands that. And as I said, more to come on on the details of that as we work through that. So information blocking, hugely important. And a very important part of what we're doing going forward. As I said, there's a real cultural change there that we really appreciate, and I know we certainly follow. We get a lot of input. We follow what's going on Twitter, on every social media, and I know there's been a lot of concern among clinicians, among certain groups of physicians. I shouldn't say all clinicians, but there have been certainly some clinicians have a lot of concerns about is their ability to exercise clinical judgment being interfered with, for example, by the requirements that information be made immediately available to patients for results and things like that. And and I think it's really important for us to say outright that we believe that it's very important for clinicians to be able to exercise their clinical judgment in cases where they believe the release of information is going to cause harm to an individual. And the rule is very clear that it allows that type of flexibility in cases where a clinician may feel that there is harm to an individual in making given those individual circumstances if information made immediately available might cause that kind of harm. And I would just point out that flexibility is completely consistent with HIPAA already says today. So it's no different than the judgment that they exercise today. And it's really important that, again, that would be inappropriate, I think, for the federal government. Sometimes we're asked for more details on on what would constitute that type of that type of exercise of judgment. And I think from our perspective, we feel like it's not the appropriate role of the federal government to be having detailed policy on on things that might interfere with the judgments that clinicians are going to make about what constitutes harm, for example, to an individual patient in those individual circumstances. So that's an important core principle here. I think it's certainly understandable that there's concern among some providers about how increased patient access enabled by modern technology can change the provider-patient relationship. I mean, the norms that we're talking about with respect to patient-provider relationship have been established over decades, literally decades and decades of paper-based records. And so it's not surprising that establishing new norms is going to require real work on the part of everyone. It's not as if that just happens without there being real work and real change in organization and individual culture and habits. So we expect and understand that that's can be wrenching at times, but that's necessary change, as we've seen happen in literally every other walk of life. And healthcare is the laggard, I think, in that regard, and it's really important for us to both recognize that that it is a hard change, but also recognize that we're the laggard in that kind of experience that we want to be able to have with with individuals. I'd also point out that the 21st Century Cures Act was passed in 2016. And the fluency final rule has been in place for a year. So it isn't as if this is something that's just been sprung on everyone. Everyone's known it's been coming, and now here it is. I think it's also important to realize that providers and technology developers are going to adapt processes and technologies to bring the provider-patient relationship into the 21st century. This is obviously it's being pushed by regulation, but it's also the opportunity. It's what the opportunity is presenting. To be able to bring that provider-patient relationship into the 21st century. And we know that's not going to happen overnight, and that the adjustment is going to be bumpy and it's going to be hard as these new norms develop that really rebalance a little bit how we think about provider control of information and patient access. But we really shouldn't, I think, have literally any doubt that that this is going to happen. It's going to happen on its own, regardless of what our regulations say, and about whether it's the right thing to do. Hopefully all of us agree that it is the right thing to do. So that's a really important aspect of it. And I will just point out, I logged into my my own provider, the patient portal the other day. I logged in, and the first thing that popped up was an announcement that from this point forward, lab results and other results will be available as soon as they are available out of the system. And it instructed me that if I had any concerns about seeing my results right away, that I should wait and not look at the results until I've been contacted by my provider, and that I should reach out to my provider if I had any concerns about this. Those are the kinds of things, as I talked about, adaptation of processes and technology that that we would expect to see going forward, and having the patient be a part of that discussion rather than have it something that that the patient is unaware of and is having information that could be made available to them, not available in ways that might benefit them and in ways that they just don't even know. So I think that's an important thing for us to all consider as we go forward. And there's also been concern about notes and notes availability. And there's been some press attention to that and other things. I would just point out again that notes have been available for a long time for any organizations who participated in the Open Notes initiative, which is literally thousands and thousands of provider organizations have participated in the Open Notes initiative, which has been a groundbreaking initiative that started at Beth Israel Deaconess Medical Center in Boston and quickly sort of spread across the U.S. as well as other countries. Those were provider organizations that were making notes available on a voluntary basis to patients. And while there's always a little bit of cultural change as patients start to read those notes and have confusion, or the notes aren't quite what they think they are, the overwhelming evidence from the Open Notes Initiative and all of that work is that that has strengthened and has not weakened the provider-patient engagement. And so I think it's this is not stuff that's being just thrown over the transom overnight. That's really important stuff that I think has a basis in where the industry has been headed on a voluntary basis, as well as from the march of technology, and is really important for all of us to embrace that, I think, as we go forward, recognizing again there are going to be bumps in the road, and we need to do everything we can to help to smooth those bumps. Another really important part of the information blocking rule is TEFCA. I know it's like an obscure kind of acronym, and we probably needed to work a little bit on branding. But TEFCA is the Trusted Exchange Framework and Cooperative Agreement. So the 21st Century Cures Act specifically said that ONC should create a governance mechanism for nationwide interoperability. And as many of you may know, there are very, very vibrant nationwide interoperability networks, as well as state and local HIEs that operate in different parts of the country. But the nationwide networks are operating on a nationwide basis and do a lot of interoperability. But one of the things that I think has been an unfortunate a dimension of that is that the activity that we see in those nationwide networks doesn't get the credit that it deserves for the interoperability that's been accomplished through a lot of hard work by a lot of people and the provider organizations as well as the technology developers, is that its scope is for provider-to-provider exchange for treatment purposes. And that's left out a lot of other participants in healthcare delivery, and that's what we'd like TEFCA to be able to help open up. So having payers be able to participate directly in those networks in a bidirectional way, to be able to offer claims data back to providers so that they can use that claims data to make better decisions on behalf of their patients, but also to be able to have providers share information with payers to be able to do the kinds of work that that they already do, but they do it in a very manual, cumbersome way, which imposes a lot of administrative burden on both sides, on both other providers and payers. Having public health be able to participate in that. Going back to what I was talking about before with respect to the pandemic, public health agencies were not getting direct access to the electronic health record information that we had spent so much time making available. And CCD information being exchanged over these networks, care quality, 5-6 million records a day being exchanged by provider organizations all over the country, but public health agencies not being able to, sort of tap into that stream to be able to perform important public health functions. So that's another, aspect of, what we'd like to be able to have TEFCA help to enable. One of the things I want to make sure that everyone understands is that, we fully appreciate, and I fully appreciate that there are a dozen ways that TEFCA could screw things up and could be a stifler of innovation. And that's one of the things that we're very cognizant of. And what we want to be able to do is say, how do we have TEFCA be something that's an enabler of innovation and an enabler of interoperability on behalf of patients going forward. And so that's, we're spending a lot of time, very focused on that. And one of the things that is a key priority for us is giving a timeline to the industry and a roadmap for TEFCA. So, I don't have that to share today. That's a lot of work that we're doing right now. As I, started the job on January 20th, I'm trying to, really help to focus the team on saying, how do we get, ourselves to a position where we can inform industry about what that looks like so that everyone in industry can make the investment decisions, both from a process as well as from a technology perspective that you need to make to be able to decide, whether TEFCA is be something that is important to you and that you believe is going to help you in your individual missions. So more to come on that, but wanted to make everyone aware that that's something that we see as very important and we're spending a lot of time on. So I'd just like to wrap up a little bit by just noting that the information blocking rule, as I said, went into effect on April 5th. Over 4 years since the passage of the 21st Century Cures Act, and I'm impatient. The industry's impatient. We all need to move forward, and so we've had a lot of time pass since the passage of the 21st Century Cures Act. The rule has finally gone into effect, and the other pieces will start to come into play. As I said, the regulations for FHIR-based exchange among providers, based on FHIR R4 based capabilities, which I think will be the foundation for the API-based type of ecosystem that all of us want to be able to get to. That doesn't go into effect until December of 2022 because it kept getting pushed out over the last few years. But we certainly want to do everything we can to make sure that that date sticks. But more important than that, much more important than that to me, is that I want to do everything I can to work with the industry to say, how do we get adoption faster than that? Let's not have regulation be the what sets the rate on our ability to have these important capabilities in place so that we can get to the next level of healthcare interoperability. So We, from an ONC perspective, we're doing a lot of work with the federal agencies to, to say, what are all the levers that we have across the federal government, VA, DOD, Social Security Administration, FDA, CMS. There's a number of agencies that are involved in health information technology, and I'm spending a lot of time working with those agencies to say, what are the levers that we can pull from our market presence as the federal government, not about regulation. Just from my experience of 20 years in the private sector in health IT, is that the federal government's market presence is often much more powerful and much more enduring than any regulations that we write. So, how do we pull all of our, sort of levers in the same direction through our market, sort of presence activities and the purchasing power that the federal government has, as well as just the day-to-day activities, to say that, we're going to try to model, sort of good behavior with respect to information sharing, protecting patient privacy, but making data available to support patient needs at the end of the day. And so that's a big part of it, and I really would love to work with industry in any way that we can to be able to help us get to a place where we're using those technologies faster than that timeline. As I said, we don't want to wait till December 2022 for all those systems to be in place. So I very much look forward to the Q&A portion of this. I really appreciate all of your engagement and attention here, and thank you very much for the opportunity to Modern Healthcare and to all of you participating. I think you're muted, Aurora.
There we go. Thank you so much for your comments and for that invitation to have the industry participate in this whole process. So we are getting some wonderful questions. First of all, I was very interested in your comments about public health in particular, because especially as you mentioned during the pandemic, we saw a little bit of marginalization and even some attacking of public health departments in ways that was not as inclusive to the rest of the industry as it should be, and would have been extremely helpful in dealing with some of the more difficult aspects of the pandemic. So how do you expect to see, or do you expect to see public health departments adopting FHIR APIs as well as hospitals in order to become more connected?
Yes, yeah. I mean, so the answer to that is a for sure yes. The trajectory and the timeline of that is a separate question. I think one of the things that, as we look into the public health data systems, and, I certainly don't want to speak for the CDC. The CDC, they are the authority on public health, but as I said, we're working very closely with them. So, please, take my comments in that spirit. I'm not speaking for the CDC, but we are working together on looking at some of the challenges that we have. And one of the things that we've noted as we've looked at the experience that we had is that part of it is related to the systems themselves being based on old standards, based on old approaches, based on an idea of one-way reporting of static reports that are a snapshot at a given point in time with very little information coming back, isolated from all of our other systems. But the other part, which I think is what you're getting to, Aurora, is that our public health system isn't really a public health system. It's actually a loosely coupled set of systems, some of which live at the federal level, some at the state level, some at the local level, some at the urban, at the city level, and some at the territorial level, the tribal level, and those are very loosely connected. And so we don't really have a system. And so that's one of the challenges that we noted as well. Part of it is about the way the technology is deployed, but the other is that we have these real jurisdictional issues that cut across that. So a lot of, I think, the work going forward is to say, how do we think about the public health data infrastructure being on a modern platform approach that has all of the sort of the cloud-based approaches and all of the things that we've learned as an industry, but that also has sort of APIs to be able to have interactive APIs, and that can help with the interoperability sort of up and down as well as horizontally. So I think that's that's definitely a part of sort of the lessons learned, and a part of, I think I know what the CDC is thinking about as it thinks about its data modernization initiative. But and a really important part of that is figuring out these jurisdictional issues and how we act as more of a system that cuts across all of those different levels, because that's not a technology issue. And I think, as probably most people on this at this conference appreciate, is that usually most of the battle isn't about the technology. It's about it's about the organizations. It's about the people at the end of the day, and having that kind of leadership and that kind of vision.
A question from our audience, Sandra Van Treese. Does the adoption of FHIR lessen the need to rely on HIEs, or does it create new opportunities for HIEs?
Yeah, absolutely creates new opportunities. So, as we think about the way that FHIR, can work in the market, there's certainly, it's RESTful APIs, and those exist, all over the place already in every walk of life. So you'll certainly have the ability to have, direct access to instances of information just directly through a FHIR-based API. So, we should expect that that's just going to exist in the wild as it does today, but that it'll become, more and more available in ways that that we're already used to, as we think about, the ways that we access apps through the Apple App Store, through the Google Play Store on our mobile devices. But I think we also need to appreciate that, within networks, FHIR-based exchange is really an important way of having a richer exchange experience within a network. And already we've seen some HIEs who are deploying FHIR-based capabilities within the networks, as well as the nationwide networks. So Care Equality, Commonwealth already have it built into their core infrastructure. At Commonwealth, I know the eHealth Exchange and Care Equality have a plan, to be able to have FHIR-based exchange in those networks as well, which is really important. What does that do? Right now, if you're having an exchange within an HIE, let's say, for example, and I'm not speaking for all HIEs, but with some HIEs, is certainly in the nationwide networks. If you request information from another entity, from another provider organization, you get back a whole continuity of care document. Maybe you're in an emergency department setting. All you wanted to know, is Aurora allergic to penicillin or not? That is the question I have at this very moment in time. And because Aurora, for whatever reason, can't answer it, if I queried another entity, the primary care physician, for example, over one of those networks, I would get back the whole continuity of care document. And I would have to, sort of sift through and find that information. A FHIR-based exchange within that network could enable me to say, just give me the medication allergies. And that's all I want is that medication allergy. So much richer experience, and something that I think that providers will find, much more beneficial and much more usable from their perspective. So in that context, I think it absolutely is something that can help to empower HIEs to make, have more usable and more adoptable, sort of capabilities in their own systems.
Dick Flanagan, the Senior Vice President at Cerner, is asking that how are you thinking about balancing compliance and burden, including costs, on providers and suppliers in future rulemaking?
Yeah, so that's an ongoing consideration. Every single day with every single thing we do, we think about sort of the what is this imposing on developers? What is this imposing on providers? And again, I spent all of my time in health IT, except for the last 3 months, has been in the private sector. So I had deep appreciation that every time there's another line added to one of these regulations, all of a sudden, and I actually was with a company, the Massachusetts Health Collaborative, where we had a certified EHR, in the system. So we actually also appreciated that a new line or a new phrase all of a sudden imposed some development, requirements on us that that had two implications. One, it costed us more that we somehow had to cover. We were a nonprofit organization, so we somehow had to cover that, and that meant higher costs for our customers. It also meant that we had to shift our priorities away from some things that our customers may have thought were higher priorities. So we certainly appreciate that there's a burden on the technology developers and a burden on the providers as well for functionality that that they may be new to them, or that they may not have thought of as being core to what they do. That those are all things that we take into account. Just a couple things. I'm not sure that I can say anything more than that, except to say that we think about that all the time. With the US CDI would be a specific example. That one of the things that there's an ongoing discussion that within ONC and with our federal partners is there's a lot of appetite for expanding the US CDI. And for those who aren't familiar with that, the US CDI is the US Core Data for Interoperability, which is that set of data elements defined by ONC, which are required to be available in all certified EHR systems. So it's kind of the baseline. It's just saying that's the minimum expectation you should have if you were going to query one of those systems and get something back. Now, it doesn't prevent anyone from adding more, but it just says that's what everyone should expect as standardized data. There's a lot of appetite for saying, let's add 30 more data elements. Let's add 40 more data elements to that. And we, from an ONC perspective, try to adjudicate that and say, let's just remember that every element we add to that list is a burden on those organizations, the technology developers, as well as the provider organizations, to make that data available. And we better have a very good justification and understanding for what value, what line of sight do we have to the value that is going to be delivered to patients and to provider organizations and to everyone in living in the U.S. From the addition of that burden across the entire system. So I can commit that we absolutely pay very close attention to that and doing what we can there. The other thing that we're doing is we have the ICAD, which is a group that's that's working with the high tech, which is about reducing burden through clinical administrative data and being able to we had one report from them, and we have a second report that's going to be coming, and that has a focus specifically on burden reduction. It also has a focus on one element of burden reduction, which is automation, and to say how do we have more and more automation to be able to reduce that burden as well. So I think that's a really important important part of this.
Amanda Hopkins Tyrell has a related question to that in regards to burden. So your opinion on data integrator companies that promise to pull all sorts of clinical and decision support data and information into a single EMR view. Are they the answer to the one-stop shop desire to have one place for clinicians to find useful clinical information they need to care for their patients?
Yeah, I certainly am not going to say that they are the answer. I think they can be an answer, and I think we just have to recognize that we've got a ton of heterogeneity out there. We've got large providers in large provider organizations, small provider organizations, federally qualified health centers, rural versus non-rural settings, government versus non-government settings, and I think it's hard to say that there is a single answer to to those kinds of local needs. I think that they are certainly one answer that could serve the needs of a particular setting. And from an ONC perspective, we don't want to do anything that stifles that kind of innovation. If people want to purchase an enterprise EHR system and they feel like that covers everything that they want to do, then that's fantastic. That's entirely up to them. Or if they want to be able to put together, they have, for whatever reason, through acquisition, through other things, they've got a wide variety of EHR systems. For whatever reason, they don't want to replace all of them, put them on a single EHR system. They want to have some type of intermediary solutions to be able to solve some of the problems, perhaps, that they're experiencing and getting the kind of more unified view that they like to have. Again, that's something that we don't want to do anything to prevent. We want to be able to say everything that we're doing allows you to decide what kind of sort of architecture you want to have that's going to best suit your needs.
A question from a gentleman I know, Matthew Weinstock, our managing editor. Is it time to review HIPAA, and what barriers that law may pose to data sharing in a digital environment? Yeah,
it's a great question. I guess I would reframe it. I don't know if it's so much to say that it's time to revisit HIPAA. So first off, I should say that that's very close sister agency of ours, OCR, who's responsible for HIPAA. So again, I'll make the caution: I do not speak for OCR. I've only been in the federal government for 3 months, but one of the things I've learned is you definitely don't want to speak for other agencies.
I was going to ask you too. Actually, that was one of my questions.
But no, we work very closely with with OCR. We have a fantastic relationship with them. We, literally day to day, working with the team at OCR. And so, I guess I would just reframe it from an ONC perspective. Again, stand corrected if OCR disagrees with the way I'm framing this, which is to say, this is, to me, it's not about, sort of revisiting HIPAA. It's just about saying, what are all of the other things that have now opened up in the world that we live in today with modern technology that really weren't contemplated by HIPAA. And so having a clear understanding of where are the boundaries of HIPAA, and I think OCR has done a nice job actually of explaining exactly what is HIPAA about, what does it cover. But I think, as we know, there's now a whole world that is being heavily populated with data that lives outside the boundary of HIPAA, and that HIPAA is silent on. And I think that that's a challenge for all of us, as an industry, as well as from the federal government perspective, to sort of figure out what is it that we want to do there. And again, ONC doesn't lead in those discussions, but we have a very, very active and highly engaged interest in that, because we recognize that the regulations and the things that we're promoting, which is, say, FHIR-based APIs, patient access to that information so that they have it in their control, and devices that they control, is encouraging a flow of data outside of where the policy framework has us today. So we appreciate that that's what the regulations imply, And that's the kind of use cases that we want to be able to enable, the patient control. But we also recognize that that there is the challenge that the privacy rules right now don't cover that space. So we have a very active interest in figuring out how we're going to move forward there, and really want to work with our federal partners as well as industry on sort of thinking that through.
Well, I really appreciate your perspective, especially this idea that, you can have rules without hindering innovation in any way. So thank you so much for the work that you have done. We look forward to keeping track of all of the work that you're going to be doing with your agency partners. Unfortunately, we have run out of time, though. So thank you, Mickey, for spending some time with us today. Thanks to the audience for the great questions. I'm Aurora Aguilar, and I appreciate your attendance today. Thank you so much, everyone.
Great. Thank you.